Welcome to AHA Science News. I'm Bob Bonow from Chicago, and I'm delighted to be here today with Dr. Paul Armstrong from Edmonton, Alberta. Dr. Armstrong and I just finished chairing a very interesting session on clinical science where we had very interesting discussions with a complex and international flavor. With us today is Dr. Young-Hak Kim from Seoul, South Korea, and also Dr. Bimal Shah from Duke University in Durham. And we're going to be discussing these four diverse and very interesting studies. We'll start with a discussion from Dr. Kim, who was the discussant of a interesting French registry of fractional flow reserve in patients undergoing coronary angiography. Dr. Kim, what's your take on this study?
FFR is a unique way to test invasively to test myocardial ischemia, and we have a couple of randomized studies to show the benefit of ischemia-guided revascularization using FFR. And the R3F study is a large registry study to represent the real-world population. So from this registry, and we can guess and what can we get from global utilization of FFR. And in their study, FFR utilization actually changed the treatment strategy about 40% for stable angina patient. It's tremendous number of patient and who is actually has mismatches between angiography and FFR evaluation. And then final result is very acceptable after FFR-based treatment strategy. So this study indicates that global utilization of FFR and actually can improve clinical outcomes irrespective of the operator's threshold to revascularization. So this is very the best way to objective finding of ischemia and guide revascularization.
So Paul, this was an interesting process in how they evaluated patients in the cath lab and then changed their classification of whether to intervene based upon the FFR. And you have some interesting thoughts on this, I think.
Well, it's the take-home for me, Bob, is obviously coupling physiology with anatomy makes sense and may allow us to make better decisions. But in understanding the process that the investigators went through, it's a little tricky. There seemed to be some situations where they actually had a procedure that was delayed after the performance of the angiography. It was a relatively low-risk population. The follow-up was to 1 year with a fairly modest number of hard endpoints. So my take is that there's a signal here that we should be doing more of this in equivocal circumstances. Pause and perhaps medical therapy in some of these instances appeared to actually be the substantial amount of reclassification. So I think and the fact that it's being published simultaneously in circulation is helpful. I think we all need to read that and think more about this.
Yeah, it was a low-risk population. Many asymptomatic individuals who presumably were sent to the cath lab because of a positive non-invasive test. And the striking thing I saw was how the non-invasive test really was not at all contributing to what we found with FFR. So the physiologic measurements invasively seem to much better discriminate the patients than the non-invasive test. We'll have to follow this one in circulation. The second study was an interesting study looking at genomics and epigenomics from Dr. Elizbekian from Alabama. She's following up on previous observations in her laboratory looking at the gene CPT1A, which has popped up as a marker for patients with high cardiovascular risk. Seeing if there's some epigenetic phenomena here related to obesity, diabetes, insulin resistance, and so forth that might be triggering the methylation of this key enzyme toward its end product, which is beta oxidation of fatty acids. And they found that indeed these epigenetic phenomena really were triggering these higher risk findings toward the association of body mass index, diabetes, insulin resistance. and once they corrected for the triglycerides, which is a target of the beta oxidation pathway, they found that there was less association. This was a interesting look at perhaps the future role of genetics and epigenetics. The population they studied, Paul, was very homogeneous, white population from Utah and Minnesota, and the question is whether these findings could be replicated or should be replicated in a more diverse population, which more representative of the United States and the world. So we'll have to see where this particular field is going. Great wrap up in that particular discussion from Dan Levy, just talking about the future of omic technology and omic science moving forward. So we'll have to keep a close eye on this one. The third presentation was also quite interesting from Canada, Paul, and that's your home base. So why don't you tell us about the paper from Dr. Tu?
So Jack Tu reported on over 500,000 immigrants over a 10-year period that had migrated to the largest province in Canada, Ontario, and really reflected on a relatively young population in the sort of late 30s, early 40s median age at the time, and then a 10-year follow-up looking at their cardiovascular outcomes, and really showed quite a diversity, not only as it relates to the country of origin, with the Southeast Asians being most prominent as it relates to risk, and but also a striking difference between the males and the females that seemed to be the case. And one of the interesting pieces for me was Leslie Curtis's highlight that not only are there 25% of the population of Ontario that were immigrants, but that this notion of cultural assimilation that we learned many years ago with the Hawaiians moving to California may well be the case in terms of playing out increased risk. So, but the take home, of course, is one size doesn't fit all, and cardiovascular risk reduction intervention may well be targeted to some of these high-risk groups that Dr. Tu and his colleagues identified.
So Bimal, you think that this is something should be looking at from the U.S. perspective also? It's kind of a microcosm of a very diverse population, and where we should be identifying new interventions?
Yeah, I agree, Dr. Bonow. I mean, the findings are really provocative, and I think Dr. Curtis's commentary, I think, was spot on. And as I sort of think about it, I think there's two strategies, sort of as you alluded to. I think we really need to know and understand these micro cultural and ethnic entities, where they are, and provide them material that's in their language, and also in a format that they can consume and understand, and actually impact their behavioral and lifestyles. But the broader question is also in the assimilation into the broader culture. How do we make sure that we continue that message for population risk reduction as well? So it's almost a two-pronged strategy.
It's a strikingly young population with lots of risk factors and high event rates. 10, 15% cardiovascular event rates over the course of the next 10 years, despite the age. And I think this does need really careful follow-up. And then, of course, talking about ethnic and cultural and international flavor, there was this very interesting study from China that you were the discussant on, Bimal. Do you want to tell us about the Chinese study?
Yeah, I'd be happy to. It was an NHLBI and United Health Group sponsored study looking at a rural health intervention in rural China. So a cluster randomized trial of 120 villages looking at a train-the-trainer model for village healthcare workers, primarily aimed at a low-cost intervention in high-risk individuals, particularly those identified with high blood pressure. And the intervention was a simple algorithm that included medication intervention, as well as looking at 4 process measures as well with regards to reduction of CVD risk factors. The conclusion from the study that was very well designed and well analyzed, there was no change in population level blood pressure. However, the incentives that were provided to the village healthcare workers was around the process measures, where they did see significant uptake in the intervention villages around those 4 process metrics. So a lot of things to learn from this study. Dr. Armstrong and I were talking. I think this is really a model of how to do well-designed, well-conducted population-based CVD risk control or risk prevention trials. 2, I think the other message that I took away from it is for pay-for-performance type incentives, you get what you pay for. And here, since the incentives were around process as opposed to outcomes, that's what they saw.
Bob, one of the things that we discussed just before starting this session was it would have been fascinating, given the Chinese medicines and diet and these villages and water content, to know what the sodium intake was across the 100-some villages and what insight that might provide relative to responsivity or not, since only a small number of patients, about a third, I guess, got diuretic therapy.
Yes.
And again, the cost of the medicines was an issue potentially in adherence. So a great start, an important model, and a huge population at risk.
Yeah, and I was wondering too what the intervention really was, and whether the health workers who are not physicians were well trained to discuss other aspects of hypertension care besides the medications, and whether the follow-up might have been tighter, because that might have been one of the reasons why the blood pressure lowering was not more dramatic. These may be interesting issues for Korea also, given your population. And do you have a rural population there too, where access to care is quite difficult?
That's right. We also we also have a gap between rural and urban cities in our country as well. However, and we have already developed the very well organized system to take care of the patient in urban and rural countries. So we developed the kind of local hospitals, in the rural side, and the government send the doctors to each hospital, and there are healthcare providers and the doctors as well. So I think it is very, and it took almost 20 years to establish that kind of system. So I think, and in underdeveloped or developing countries, and making a very nice systemic system to take care of the people in the rural countries is very important for nationwide healthcare.
Yes, and of course for China, there's huge challenges for their large rural and growing population. With lots of stroke and cardiovascular disease, so we need to stay tuned to whether they can actually improve upon this early knowledge they're getting. Well, this was a nice session, lots of knowledge, lots of new things to think about, and hopefully new progress in the future. Thanks to Dr. Kim, Dr. Armstrong, Dr. Shah, and thank you for joining us at AHA Science News.